friends and colleagues, good afternoon. I have the honor to be with you tonight. I'm going to moderate this interview around the retina around the world. I am so pleased to present our guest today. He's Dr. Hussein Khan from Pakistan. Dr. Hussein, good afternoon.
Thank you, Samir. It's afternoon for you. Here it's already good night. It's 10 p.m. here.
Yes, we are 7 p.m. right now in Egypt, and until 10 p.m. There are 3 hours different between both countries.
It's nice to see you. It's
Thank
great.
you, Dr. Hussein.
Thank you so much,
Dr. Hussein. I will ask you some questions, social questions, about first about your city. In which city you are living?
I'm living in Lahore. Lahore is the capital of province Punjab, and Punjab is the biggest province in Pakistan.
Yeah,
it's the capital of Punjab. Yes, it's a big city like Cairo in Egypt.
Yeah. Actually, do you work in a university or in a public hospital, or you have a private practice? What's your, where are you working?
So I'm working in a postgraduate medical institute, and it is affiliated with a hospital, and it is also affiliated with a medical college. So in my institute, we are training the young doctors for bachelor degree, and then we are training for fellowship in different specialties, including ophthalmology. And in my department, we are also training for a second fellowship in vitreoretina. So we are training for 3 levels of students.
Yes.
That is undergraduates who are going to become doctors like MD or MBBS. And second grade are the fellows in ophthalmology. And third, we are training the second fellowship trainees in vitreoretina.
But you don't have a private practice or private clinic?
Yes, I do private clinic because in my country, the government set up, we have to work up to 2 p.m. from morning 8 to 2 p.m.
In the institute?
In the institute, yes. And then in evening, I'm free, and afternoon, I'm free. And in evening, from 6 to 8 p.m., I do my private clinic.
Okay. I want to have an idea about your surgeries. If you are doing vitreoretinal surgery or vitrectomy, for example, in the private clinic, it costs how much money to compare it with Egypt? In dollars. I will tell you in Egypt, in our country.
It's a big secret today. Yes.
Okay.
It depends. It depends on sometimes the situation, but usually the vitrectomy in Pakistan is about $1,500 US, or from 1,500 to 2,000 US usually in private sector.
You know, in Egypt, it is almost equivalent to this. It is from $1,000 to $1,500. It is, I think, it is the same situation in our country. So there is not a lot of difference between both countries. Who influenced you to take this branch of vitreoretinal surgery? Sure, there is somebody as a mentor for you who you like to be like him.
Yes. Actually, during my fellowship training, my trainer and supervisor of our primary fellowship training in ophthalmology, he was a vitreoretinal surgeon. So
he's from Pakistan or from other part of the world?
He was from Pakistan, but he was trained in Oxford, in UK, and he was one of the leading surgeons in Oxford at that time. He left Oxford and shifted to Pakistan. So while doing training with him as an ophthalmologist, as he was doing all the time retinal surgeries, so I found interest in retinal surgery in sense that at even that time, there were a lot of new things in retinal surgery every day, and it was more like a interesting, innovative field than the other fields in ophthalmology. I don't say other fields are not innovative, but I felt that it is more ever changing and bringing something new in ophthalmology every day. Because I know in my early training of ophthalmology, some of my seniors said that no one gets blind from any disease of the eye part except the retina. So the
Yeah,
only retina
this
is
is
that
true. This
from
is
where
true.
someone gets blind forever. So I thought, why not? I should start working for that tissue. So that was the beginning, and obviously he was very good teacher. Unfortunately, he died in his young age,
No.
and I am taking his legacy. And Alhamdulillah, we have now all the levels of trainees in Vitreoretina. We are training the Vitreoretina Fellowship of 2 years of our College of Physicians and Surgeons, and it is the only Vitreoretina Fellowship that has an exit exam. You see, most of the vitreoretinal fellowships, they don't have an exit exam, but
Yeah.
in our fellowship, we have a proper written and clinical viva exam in second fellowship for vitreoretina. Yes, thank you.
You know, most of us has a fellowship in some part of the world, in the United States or in Europe. In which part you practice or you did your fellowship?
So first I did fellowship from Pakistan in ophthalmology, and then I did fellowship from Glasgow. This is FRCS
Yes.
from Glasgow. And then I again started my training in fellowship for vitreoretina in Pakistan. Meanwhile, I shifted to Germany, LMU in Munich, and there I started my training in vitreoretina. And after finishing my fellowship in vitreoretina in Munich, I worked under the supervision of Professor Kempik, and there was Dr. Armin Wolf at that time. And after finishing that fellowship, I came back and I finished my fellowship in vitreoretina in Pakistan also.
Dr. Hussein,
Okay.
do you have any
Yes.
hobbies you want to practice?
Yes. I have hobbies, but hobbies change with the passage of the time. When
Yes.
I was a child, then my hobby was stamp collection,
Yeah.
and I like to read the different cultures of different countries. I thought that I should learn about the different cultures of different countries, how they live, how they eat, how they talk, and how they spend their leisure time.
Yeah.
But with the passage of time in teenage, the hobbies little bit changed, and the hobbies changed to the I become
There is no letters right now and no stamps. We can't find stamps.
so nowadays. Obviously, there are no stamps, so hobby is gone with the wind.
Yeah.
So nowadays, in the teenage, my hobbies was I start reading poetry in my native language, and I love to read poetry till the day. And also, I played on the musical instrument, that's violin. I learned how to play the violin.
Yeah.
But nowadays, as a retinal surgeon, I have a little bit less time, but my hobby has little bit shifted to the other phase. As I approaching the 40 years, so my now the biggest hobby is I love cooking. I follow many international chefs, and I take their recipes. And as a retinal surgeon, I use the innovations in retinal surgery too, and similarly I use the innovations in cooking. So I am relatively a very much good innovative chef than a rather than a retinal surgeon. So I cannot bring changes in retinal surgery daily, so I do experiments on cooking daily. So nowadays do, and I love to travel, to that my childhood passion to learn about the different cultures. For this thing I have to travel, and I travel different countries to see the cultures of different countries, how the people
What
live.
countries do you like to visit? What the best
Samir,
country?
I mean, it doesn't depend on the country, but I need to go to their villages, their pure life, not a city life, their pure cultural life that I want to explore. For example, if I go to an American city like LA or New York, but I have to rather to go the suburbs, or I have to go the small cities, how their culture is, and how the people live, how they spend their leisure time, what they eat, what is the food recipes they have. So I do such like job work when I am traveling to the other countries. So, but unfortunately, in the last 2 years, the COVID stopped my hobby. So then only hobby is now cooking and innovations in retina.
So Hassan, which food do you like? Is it seafood or the steak, or what is the best for you? Because I know in your countries like India, there is a lot of spices in your food. Which food do you like?
So in meat recipe, I love meat. All the day I can eat the meat in breakfast, in the afternoon, and any meal I can eat the meat. But I like the beef.
Yes.
Beef. I like the beef and then the seafood to some extent.
Okay. Do you like your children to have the same career, or they prefer to go another career?
Difficult question.
Yeah.
Samir, to my understanding, I never push the children to become a doctor
Yes.
or to follow my career. So I have one beautiful teenage son and one daughter. My son is not going to adopt the medical field,
Yes.
as he decided that he has to go to the engineering phase. He
Oh.
want to become bring the revolution in software industry, something like this. So
Yeah.
he is going to become an engineer, inshallah. But my daughter is following me. I never pushed her. So she had the plans to
We
become
can't push them, Dr. Hassin. We can't push
yes,
them.
yes, obviously
It's very
nowadays.
difficult.
Yes, I agree. But she has the plans to become the doctor. But obviously, she is going to do something more advanced medical fields than routine ones.
Dr. Hassin, I want to ask a question which is somewhat difficult. Sometimes the patients after surgery complain of poor vision, or there is a problem post-operative. They do a lot of complication, or they complain to the police. In our country, if this happened, they will go to the police and complain. It happened in the same way in Pakistan.
Samir, till the last few years, if you go 15 years behind, then it was the similar. But in 2006 and 7, our medical commission has made an healthcare commission. So
Yes.
any patient who has a complaint to the doctor, he cannot go to the police, he cannot go anywhere. He has to report to the healthcare commission, and
Yes.
healthcare commission will do the inquiry whether it is a negligence of doctor or whether it's the course of disease that patient had, that symptoms or that end of disease. So after the healthcare commission, that scenario of doctors to going to the courts and to the police is relatively very much less in our country now.
Yes, this is a nice system. We hope we can apply this system in our country.
Yeah.
Dr. Hassan, we now finish our social part. If you like to add anything, you can add it right now, because we are going to.
So, Sabi, the best thing is that I like this activity of Egyptian Vitreoretinal Society, and I'm thank you Egyptian Vitreoretinal Society and you, because it happened first time that someone is talking to me not about the retina.
Yes. We have to change the mood, Dr. Hassan. We have to change.
Whenever I talk with someone on Zoom or in any meeting, they are talking about what to do with the ILM, how to shift the retina to that side, what
That's
to do
right.
with that retina. So I like this activity, and really I highly appreciate and convey my appreciation to your society members and the people who generated this idea. It is way beyond my imagination that you have done.
Thank you, Dr. Hassin. Thank you. And
Thank you.
all the members of the Vitreoretinal Society actually likes you and respects you because you are a very nice man, Dr. Hassin.
Thank you so much, Samir.
Dr. Hassin, we are going to hold for a few minutes and
Okay.
we will come back again. Please, for all the audience, stay with us.
Thank you, Samir. Thank you, GVRS. Thank you so much. Well done.
Back again right now. Dr. Hassin is going to share his presentation about optic pit. Please, Dr. Hassin, share your presentation with us.
So, thank you, Egyptian Vitreoretinal Society, Dr. Samir Arbaha, for this kind invitation. And my topic of presentation is a novel technique for treatment of optic disc pit. I have no financial disclosure. I will just go for the first case of this presentation. This is a 48-year-old male, and he has a counted finger in his left eye. And the patient has optic disc pit and secondary macular hole. From secondary macular hole, I meant that this patient underwent one surgery for optic disc pit already, and he got the macular hole after that surgery. So this is the primary history of the patient. He underwent 23 gauge pars plana vitrectomy, underwent ILM peeling and filling the optic disc pit with the homologous whole blood for optic disc pit and serous macular detachment. But after that surgery, patient got secondary macular hole. Here you can see, and here is the optic disc pit is still open. So practically, we don't have much options for these cases. So if you have a secondary macular hole, what you can do, and if you have open optic disc pit, then what you can do. So practically not much valid options available in the literature. So we gone through the literature but couldn't find a reasonable or satisfactory treatment option. So we did the brainstorming, and I had the idea of doing something new for this case. So I'm just sharing you the pit area, and I'm sharing you the size of secondary macular hole. This is 620 micron meter macular hole in the minimum diameter, and you can see the fluid under it. So what we planned, we were in difficult situation. So how to close the secondary macular hole and how to close the optic disc pit. All the used methods in literature, they had not very good success rate. So what we planned for 23 gauge vitrectomy and plug the pit with the punctum plug. That was the novel idea that we have generated. The punctum plug are usually used to close the punctum in cases of dry eye. So those were sterilized. So we planned that if we can insert the punctum plug into the optic disc pit, that may close the optic disc pit. But we didn't have any idea or any experience about it. So we did a lot of homework for this, and we planned for this. And then the secondary issue was the macular hole. How to close the macular hole? Either to take the retinal graft, or how we should close it. So we plan to close the secondary macular hole with the human amniotic membrane graft. So both the ideas in this plan were new or relatively new, and we executed these one. So these are the punctum plug that are routinely available. You can see the shape of punctum plug that is like a peg. So it can easily, so we planned that it can easily go through the punctum, but to choose the punctum plug size according to the pit size was very difficult thing for us at the beginning. So we choose the optic disc pit size through the optical coherence tomography, and then choose the size of these punctum plugs that are used for the punctum closure. So here I will show you the surgical procedure. So here you can see we set the system of 23 gauge pars plana vitrectomy. You can see easily here, this is the optic disc pit and this is the secondary macular hole. We choose this type of punctum plug to close the optic disc pit. Here you can see the punctum plug. I am holding it with the end grasping forceps and going inside the eye with the end grasping forceps. So here you can see I am already in the vitreous cavity and I am just plugging it in the optic disc pit. The technique is that you can easily go inside and slightly push this punctum plug into the optic disc pit. So here you can see that I have plugged it in the pit and it is nicely stable in the pit. And it looks like it has been made for this disease, although it has not been made. You can see the punctum plug is already in the optic disc pit and it is well sized and it is positioned. So here you can see how the punctum plug is nicely plugging the optic disc pit in this case. Now we have the second issue of secondary macular hole, and I am just lying over the macular hole, the amniotic membrane graft with an grasping forceps. And I am not plugging it in the macular hole, I am just putting it over the macular hole. So here you can see at the end of the surgery, our optic disc pit is closed with the punctum plug, and here the amniotic membrane graft is overlying the secondary macular hole. We are not plugging the macular hole, we are just giving a scaffold for to closure the macular hole. Here in the post-operative period, you can see here is the punctum plug and the optic disc pit is completely closed. Here you can see the optic coherence tomography in OCT. The punctum plug is lying here and it completely closed optic disc pit. Here you can see. This is the other way scan, other section. Here you can see the punctum plug and it is completely closing the optic disc pit. So these are the few more serial photographs. These one. And here you can see the secondary macular hole is closed with the amniotic membrane graft. Here you can see the punctum plug is lying over here and secondary macular hole is covered by amniotic membrane graft. The best thing about the amniotic membrane graft, not to plug in the hole, rather to place it over and give it a scaffold to close it, that you can see the closure of the hole is like a primary macular hole closure. All the layers has been moved centripetally and close the macular hole in primary hole closure. The patient got a significant good vision in the post-operative period, and at the 4-year follow-ups of this patient, the patient is still hanging on 660 vision, and I think we have done our job. In nutshell summary, plug the optic disc pit with the punctum plug is a practical option and can be done safely with the good post in optic disc pit. Punctum plug may be used as a primary option in optic disc pit surgery to close the optic disc pit. And for the secondary macular hole or refractory macular hole, the amniotic membrane graft can be used to close the macular hole as a primary closure and even for the secondary closure. So this is my presentation. If you have any questions, I am here. Thank you again, Professor Amir and Egyptian Vitreoretinal Society for arranging this excellent session. I am highly grateful and hope to have many more sessions with you in future. Thank you so much.
Thank you, Dr. Hassan, for this exciting technique. Actually, it's very interesting technique. I like it. Okay, I have a few cases of optic pit, so I want to ask you a few questions about this technique. First of all, you have the amniotic membrane. Why you didn't use the amniotic membrane to close the optic pit and to close the macular hole in the same time?
Okay, it's a very nice question. Samir, in 2017, I tried to close the optic disc pit with amniotic membrane graft.
Yes.
And in my all three first cases, the amniotic membrane graft dislodged from the optic disc pit.
Yes.
So it doesn't stay there.
It doesn't stay.
Because our understanding, it's a rare disease, as you know. You hardly get one patient in 3 months or 2 months. It's not as prevalent as retinal detachment. So not much cases. But in 2017, our all three cases that has been plugged with the amniotic membrane graft in the optic disc pit, they sooner or later dislodged, and we got the idea that there is a push of the fluid from the pit side that doesn't let the amniotic membrane graft to stay in the pit. So we stopped using the amniotic membrane over there.
My second question, the picture of the macular hole you demonstrated in the beginning of the presentation, there was a macular hole and a cuff of fluid around the macular hole. But I can see a sensory detachment extending to the optic pit. You know, in the optic pit, usually there is a fluid extending from the optic pit till the macula. I can't see this. So why did you put this puncture plug to close the optic pit?
So this patient came to my colleague in the first visit. When he was never been operated, he presented with optic disc pit and serous macular detachment. At that time, he has only the optic disc pit and serous detachment, and there was connection between the optic disc pit and serous detachment. He did the surgery. He did the ILM peel and closed the plug, closed the pit with the homologous whole blood.
ILM.
And ILM peel. The only mistake he did the ILM peel in circumferential in 360 degree rather than only the nasal one. So he got the secondary macular hole, then he referred it to me. The cuff of fluid at this time was not connected with the pit. But when I was going inside, so I didn't want that I can leave any disease unattended. So I just closed it. And you see, after putting the plug inside and putting the membrane, this serous fluid is nowhere in the layer. And even there is centripetal movement of the layers, and it's a type 1 closure of the macular hole. Yes, I agree. When there is no connection of the pit with the serous detachment, you usually don't need to do it. But I have seen the case where I didn't address the optic disc pit, as it was old optic disc pit, and patient had a history of 10 years, and he was navigating on beyond the perception of the light. I tried to operate it, the patient, and I didn't put anything inside the optic disc pit. Will you believe, after the surgery, when PVD was induced and I removed the membranes over the pit, I left the pit alone. But after the 2 months, patient got again the serous detachment. From there to the connection.
I think it is a good idea because the serous detachment may occur again after a few months, as you said. The third question, I did a lot of cases of amniotic membrane in macular holes since 2016 when Rizzo published his first paper about this. But my difficulty in these cases is that the amniotic membrane stays forever. When I close the macular hole, this amniotic membrane, it stays forever. It doesn't go all the time. The macular hole is closed, but the amniotic membrane also is present. I know. I'd like to know your experience in these cases.
Yes, Samir, it will not go away unless you will not remove it. It will never go away. I have the oldest case of 2017. It's almost 5 years. So if the patient doesn't much big scotoma on the perimetry, then you can leave it. If the patient feels a scotoma over there, then you can go inside and just remove it in the type 1 closures. If you have a type 2 closure, don't remove it, because I removed in a type 2 closure and the hole again reopened.
Oh.
So it's only for type 1 closure. For type 2, if you will pull it out, their lips again open. So I don't have a good experience to removing it in type 2 closure, but only for type 1 closure. It wouldn't go if you will not remove. It's not like on the cornea. At the cornea and conjunctiva, it goes away with the time. It
Exactly.
gets thinner. But
Yes.
on the macular hole, it stay as
Stays
you put
forever.
it yesterday.
Stays forever.
Yes.
Dr. Hussein, we'd like to thank you. And this is my question. If you like to add anything about your presentation or anything to the Egyptian doctors, the vitreoretinal surgeon in Egypt, you can add it right now.
So regarding the optic disc pit, I would love if somebody from the Egyptian Vitreoretinal Society would like to join me on this novel technique, because we are the innovators of this technique for optic disc pit, and I have already a series of 7 successful cases.
Yes.
So I have the 7 cases, because I don't get the suitable cases many, and rarely we get the optic disc pit case.
Yes.
Very
It's very rare cases. Yeah.
Yeah, so I would like if people from Egyptian Vitreoretinal Society or Egypt, they want to join me in this research project. So, because you see, you wouldn't find a best technique of optic disc pit per surgery till the day. If I will say my technique is best, these will be my only words. When my Egyptian friends will do it and they will conclude it is the best, then it will be seen as a best technique.
Yes. Yes.
So I would like a multi-center trial of this technique. So I will be awaiting the response of my Egyptian colleagues if they want to join in this project.
I think they all will hear you, and anyone want to participate in this multi-center study, they will contact you.
Thank you so much.
At the end of this, yes. Do you like to add?
If you have a time, I can speak for 1 minute more.
Yes. No, take your time.
So that's my first objective, that we can do this one. And second, I want much more harmony and friendship among the colleagues of different countries. Like Egyptian, I have so many friends from the Egypt, from not only vitreoretina, but also from the other fields of ophthalmology also. So we would like to have a much more collaboration with the Egyptian Vitreoretinal Society, as I am a international coordinator of Pakistan Vitreoretinal Society. So we can have a different project or mutual projects for Pakistan Vitreoretinal Society and Egyptian Vitreoretinal Society. And I would love to thank all the EGVRS people. I always find the EGVRS friends so friendly. Whenever, wherever I meet, they are all smiling, from Ashraf Charawe to Hani Hamza to Samir to Mbabi to all the very dear friends. So I hope we should have a lot of collaboration. But last and least, we are holding an Afro-Asian Congress this year in Lahore, Pakistan. So I would like to have a full convoy of retinal surgeons from the Egypt. I am inviting and expecting as many Egypt in Lahore as many are there in Cairo.
Inshallah. Thank you so much, Dr. Hussein, for this invitation, and thank you for your presentation. Thank you for everything. Actually, we enjoy this interview with you. I think all the vitreoretinal surgeons in our country will like this presentation, and we hope to see you here in Egypt in the next meetings to participate your experience in vitreoretinal surgery with us. And usually we meet in the States and in Europe, but we like to see you here in Egypt. This interview will be presented in Ramadan, and I will tell you the exact time of this so you can follow it and see it and tell your colleagues there. At the end, thank you so much from me personally, Samir, and from all the board of the Vitreoretinal Society, Egyptian Vitreoretinal Society, and all the vitreoretinal surgery in Egypt. Thank you so much, Dr. Hassim.
Thank you so
Have
much.
a good time. Thank you. Thank you so much.
Thank you.
Bye, Dr. Hassim. Thank you.
Thank you. Thank you. Take care.
Thank you.